Hello, good afternoon. Well, a really warm welcome to day 2 of the Duchenne Care Conference organized by the World Duchenne Organization. Welcome to the participants again, to the translators, but also welcome to the speakers of today. We are again having a lineup of fantastic speakers, as you can see in the program. And thank you so much for taking the time to help the global Duchenne community to learn more about many aspects of Duchenne care. And as we all know, the best we can do to improve the lives of people with Duchenne and Becker muscular dystrophy is to provide and adhere to good care. Very often, I would say daily, we receive messages from families and clinicians asking to send them the cure, as they think there is magic in the drugs which are currently developed and approved, and that these drugs will solve all problems. But these drugs can probably help to slow down the progression of the disease, as Professor Aartsma will explain, but that they don't change the need for good care. So for the clinicians and families, good care has really clearly proved to be effective in slowing down the progression of the disease, and if applied well, can double the lifespan of people living with Duchenne. The new approved drugs can contribute to this, but a lot still has to be proven in this field. So the current guidelines for optimal care for Duchenne include many drugs which are used off-label, so not specific approved for Duchenne. Think steroids like prednisone, we heard about yesterday, and ACE inhibitors and other cardiac medication we will hear more about today. So as we received a request after the Duchenne Care Conference 2023 to include in our next conference information about drugs which are approved for Duchenne over the last years, we did this. We included it here. So that's the beauty of giving feedback. So if you receive a request or for feedback after the conference, please respond. Our first speaker is Professor Annemieke Aartsma-Rus, and she will speak about the currently approved drugs for DMD around the globe. She is professor in translational genetics at the Leiden University Medical Center in the Netherlands. And besides being ranked since 2015, I think with the exception of 1 year, right? As the #1 expert on Duchenne muscular dystrophy by Expertscape, she is well known for her work in translational research in Duchenne and other diseases, but she's also famous for translating complicated scientific models, including the ones about drug development, into lay language. She traveled around the globe, she travels, I should say, around the globe, not only to speak to colleagues and experts in her own field, but also to educate healthcare professionals and families. She has been chair of the TREAT-NMD and takes part in many advisory boards on several subjects, including the funding of research projects by patient-led foundations. So Annemieke, thank you so much for being here again today and taking the time to enlighten us with the stories about the new drugs. Thank you.
Okay, thank you. Mm-hmm. Thank you very much, Elizabeth, for the kind introduction. And I'll share my screen, and if things go wrong, I'll hear it. It's actually really nice that Elizabeth started her introduction by talking about care, because that's also how I wanted to start my talk. Of course, therapies are important, but if you see what good care can do, then compared to time where Duchenne patients did not have good care and management, I think it's already impressive. And I actually read a paper today, and I discussed it on Twitter, where the difference between respiratory care was dying at 18 years old and now dying 10 years later, and that's just respiratory care. So I think it's clear that we need good care, and all these therapies are on top of the care. They're not replacing the care. Suzanne said you're not allowed to take screenshots, but please, if you want to read my disclosures, do take a screenshot now, because I'm not going to read them. And because we need the time to discuss the approved therapies. So before going into the approved therapeutic approaches, I will very briefly give some context about Duchenne and dystrophin and the pathology, because we need that to understand how the different therapeutic approaches work, and what they do, and also what they do not do. I will discuss dystrophin restoring approaches, stop codon read-through, and exon skipping. I will focus on microdystrophin gene therapy because that's the most recently approved one. And then I will also spend time on the 2 other recently approved drugs targeting pathology for vamorolone and givinostat. But first, the context that I promised. So Duchenne patients don't make dystrophin, and dystrophin acts as a shock absorber in the skeletal muscle fiber by connecting the skeletal internal skeleton of the muscle fiber to the connective tissue surrounding the muscle fiber. And in that way, it prevents muscles from being damaged when they contract. And you can see a schematic depiction of dystrophin here, and you see the actin binding domain at the beginning binding to the cytoskeleton. And you see at the end the dystroglycan binding domain that binds to the extracellular matrix, so the connective tissue surrounding each fibers. So the 2 important domains, the 2 business ends of dystrophin, are located at the beginning and the end of the protein. And this is why if you have a mutation in the middle of the protein that does not disrupt the reading frame, you can produce a dystrophin that contains the actin binding domain and the dystroglycan binding domain that is partially functional. And these dystrophins are found in Becker muscular dystrophy. When you have a mutation that disrupts the open reading frame, the translation is truncated prematurely, and you get only the beginning of the protein, and this linker to the connective tissue is lost, and these mutations are found in Duchenne. And we'll go over the genetic cause of Duchenne and Becker in 2 more slides because it's important for the dystrophin restoring approaches. So again, here we have a frame shift. So you see a deletion. Exon 48, 49, and 50 are missing. You see 47 doesn't fit to 51. So when this messenger RNA is translated, everything goes well until exon 47, and then the frame is shifted, the code becomes unreadable, starting in exon 51, the wrong amino acids are included, and then protein translation stops. So you make only the beginning of the protein, and this is not functional. Now here we have a larger deletion, so now also exon 51 is missing, but 47 fits to 52. So the reading frame, the genetic code is not disrupted, and now protein translation can continue from start to finish. For most protein, missing a little bit of the protein, that would be enough to make the protein non-functional. But dystrophin is rather unique because the important domains are at the beginning and the end. So a protein that misses a little bit in the middle can be partially functional. And we know this because this is found in Becker patients. So as dystrophin stabilizes muscle fibers during contraction, without dystrophin, there's continuous damage during normal use of the muscle. This leads to chronic inflammation, scar tissue formation, so the muscle is replaced by fibrotic and adipose tissues. Regeneration, muscle repair is impaired, and then therefore you lose continuously muscle tissue, and with that also muscle function. And this happens in Duchenne, but these processes also happen in Becker. So they start later and they happen slower, so the disease trajectory is slower, but it's really important to remember that this does also happen in Becker. And why is that important? Because the dystrophins that we're restoring with the different therapeutic approaches don't make normal dystrophin, but make a Becker-like dystrophin or even smaller. So these pathological processes will not stop, they will slow down if these therapeutics are effective. So now before we go into the approved therapy, some challenges that it's good to be aware of. Muscle tissue is very abundant. So 30 to 40% of our body is muscle, and we have over 700 different skeletal muscles, and almost all are affected in Duchenne. And that means that if you have whatever therapy and you manage to reach a single nucleus in a few muscles, that will not be enough. You really need to deliver your therapy to the majority of muscle fibers in the majority, or ideally all skeletal muscles. And also, once muscle function is lost, that is usually irreversible. So the time of intervention matters, and it's not realistic to think that when someone lost ambulation, if you then treat that patient, that they will start walking again. You can slow down disease progression from that time, but you cannot undo the function that's already lost. So now we're going to go into the different approach therapies one by one. And stop codon read-through, I will start with this one because this was the first one that was approved specifically for Duchenne in 2014 in Europe. So how does this work? This works for a very select type of mutation, and that's the so-called nonsense mutation. So down here we have the mutation that I just explained, the one that disrupts the reading frame. And you can see if you disrupt the reading frame, the wrong amino acid is included, and you see a lot of these stops. There is one type of mutation, the nonsense mutation, where one amino acid, so the code for one amino acid is changed into the code for a stop. So normally you have the beginning of the reading frame here, the translation starts, and at the end, here it stops. And now instead of here, the code for an amino acid, there's the code for a stop. And this doesn't make sense because it's in the middle of the transcript. So that's like the book is finishing mid-book, doesn't make sense, but the cell uses this. For these type of variants, you can do stop codon read-through and then suppress this stop that's at the wrong location, and then you can read from start to finish, and the whole code is still there. You cannot do this when there is a deletion or duplication, when there is a frame shift. You cannot do this because even if you manage to suppress all these stops, the code is wrong. The wrong amino acid is encoded, so you will still not get a functional protein. So this only applies to about 10% of patients with a stop mutation or a nonsense mutation. So the current state, ataluren is the approved nonsense suppressor. It's conditionally approved in the EU, and currently it's approved for patients who are ambulant 2 years and older. Because it's conditionally approved, it needs to be re-evaluated annually. It's marketed currently in several European countries, in the countries in the Middle East, and countries in South America. So it's definitely not available everywhere. I mentioned already that it's only for nonsense mutation, and it was conditionally approved based on a clinical trial. And then 2 confirmatory studies had to be performed. The first confirmatory study was inconclusive. So it didn't show that the drug worked, but it also didn't show that it didn't work. So then the company was requested by EMA to do a second confirmatory study. And that study was completed and the results are in. And this showed that after 1.5 years of treatment with this ataluren, patients who were treated could walk 16 meters more in the 6-minute walk test compared to the placebo group. This was significantly different, but the question, of course, is 14 meters in 6 minutes, is that clinically relevant? And well, the question is, well, that is for the regulators, of course, to assess whether that is relevant. Because the ataluren is already approved since 2014, there's also real-world evidence. So there's the STRIDE database where data is collected from patients who are commercially treated with the compound. And when you compare these patients to the natural history, there's a 3 years delay in loss of ambulation. And then the question is, how comparable is this data to the natural history? Is it the same? Is it different? And then the EMA did not approve and did not extend the conditional approval based on this data. So faced with this 14 meters, they said this is not clinically relevant, and this data they didn't take into account. So the conditional approval was not extended. And then EMA makes a recommendation and the European Commission has to formalize this, but they did not. And they said instead, the data needs to be re-evaluated because there were some procedural mistakes. So at the moment, ataluren in Europe is still marketed, but the data needs to be re-evaluated. I am not sure what the status is of ataluren with the FDA based on this data, but for now it's still available in Europe. So with that, we're going to move on to exon skipping. And I'm not going to dwell on this very long because this is another one that's been approved for quite some time. And well, confirming data is being collected. So how does exon skipping work? We're back to our deletion of exon 48 to 50, and we know exon 47 doesn't fit to 51. So each exon contains genetic code, and we've already seen 47 would fit to 52 because that leads to Becker. If during the splicing process where these exons, these pieces of genetic code are connected, we could block exon 51 from being included, that would restore the code. Because then exon 51 is skipped, 47 is connected to 52, the reading frame is restored, and now we can produce a Becker-like dystrophin. So current state of the art, there's 4 AONs approved targeting exon 51, 53, and 45. So this is mutation specific. So depending on where the mutation is and which exons are involved, you need to skip a specific exon. And you will say there's 4 approved and only 3 exons. That is because exon 53 has 2 approved AONs. And this applies to about 30%, 30% of patients. So far, approval is only based on dystrophin restoration at very low levels, and on average around 1%. And the question is that enough to slow down disease progression? And that is something that's currently being tested in clinical trials. What is clear is that there's room for improvement. So if 1% slows down disease progression, 10% is expected to slow down disease progression more. So there's work ongoing to improve the delivery of these AONs, so the compounds that induce exon skipping, to skeletal muscle and heart. And there's also people trying to work on the applicability, because now you need to develop for each exon specifically an AON, and that takes a lot of time and effort. So considerations, how do you improve the uptake? There's 2 types of approaches. Either it's targeted, and those are the transferrin receptor conjugated AONs, and untargeted. And these are, here they add a small peptide that's arginine rich, and that improves the uptake in general, and therefore also in skeletal muscle. And I already mentioned the applicability. So with that, we're going to move to gene therapy, and I'm going to dwell on this slightly longer because this is more recently approved, so there's probably less knowledge about this. So what is gene therapy? Duchenne patients cannot make a dystrophin because they have a mistake in their gene. What if we provide the genetic code for dystrophin to muscle? Then the patients can use that to make their dystrophin. So how do we deliver genes to muscles? And again, it's not enough to do it to one muscle fiber. You need to do this to all the 700 different muscles. How do you do this? You use a viral vector. There's just one virus that can deliver to muscle, and that's AAV, adeno-associated virus. It can deliver to muscle because it's small. But because it's small, it can contain only small genes. And dystrophin is a very large gene. So we need to engineer the dystrophin. We need to make a microdystrophin that only contains the most crucial codes and some extra things like viral sequences and a promoter to make sure it goes into the particle, to make sure it's expressed only in muscle, and then make it fit into an AAV. So there's different ways that companies have gone about this, and you can see the 4 that are currently in clinical trial here, and this one is light blue because this is the one that's been approved in the US. And what you can see, they all have the actin binding domain, they all have the cysteine-rich domain that binds to the dystroglycan, and then it differs, the middle differs a little bit. Obviously, each company will say the one that we use works best, but as you can see, they have more similarities than they have differences. You can also see that different companies use different types of AAV. So you have 7, 4, 8, and 9. They all go to muscle, but they are slightly different on the outside. So considerations. AAV normally is not pathogenic. So as we are here in the audience, probably about 50% of you has seen AAV and has antibodies to AAV, and you never realized you were sick because you didn't get sick. However, if you want to use AAV to deliver gene therapy, you need really high doses. And these very high doses, about 200 times more than you have erythrocytes in your body, this will cause side effects, and this will cause sickness. And that is because you just give a lot of AAV viruses, but also because a lot of this goes to liver. We say AAV can deliver to muscle. Yes, it can, but very high exposure in the liver, and that means that will also lead to problems. There will be an immune response.
Annemieke,
yeah?
Sorry, there are requests if you can speak a little bit slower.
Okay, sorry.
No, it's no sorry. It's sorry. I'm sorry to interrupt you. Sorry.
Don't worry.
Okay.
So I will try, and by all means wave if I talk quick again, because I don't know whether I will manage until the end. So if you deliver these very high doses of AAV, an immune response will occur, even if you suppress the immune system, which is done with gene therapy. And of course, when you've seen AAV in the past, just during a normal infection, there will be an immunity to AAV already. And that means you cannot get AAV gene therapy, not in a clinical trial, but also not commercially. And this is why antibody tests are done during screening. And the reason that you cannot receive AAV gene therapy is because the immune response that you would get if you've seen it already, giving the really high dose of viruses, that would be very dangerous and potentially lethal. So what is the current state of the art? Elevidys, the AAV microdystrophin from Sarepta, has been approved in the US and several countries in the Middle East. But this is, again, an accelerated approval, so confirmatory studies are ongoing. And you will see a pattern for the dystrophin restoring approaches. Everywhere, confirmatory studies to show functional effects are done. The approval is only for patients who are 4 to 5 years old, and the patient should not have a deletion that includes exons 8 and 9, and we'll get back to that. So on top of the approval, there's clinical trials. So there's the confirmatory studies from Sarepta and Roche for the Elevidys to show that there is a functional effect, but there's also clinical trials by others, Pfizer, Solid, REGENXBio, and Genethon. And so far, over 500 Duchenne patients have been treated with one of these compounds. And what we know is that if you give that the right dose, you can get very good microdystrophin expression. In the majority of fibers, over 50% and well, up to 80% or even more, and at high doses, 40, 50% or even more doses of total protein compared to wild type dystrophin. So this works. You can deliver the AAV, can deliver the microdystrophin gene to the majority of muscle fibers. However, there's also side effects, and these can be severe to very severe. And so far, sadly, there have been 3 people who died after receiving AAV9 gene therapy. The severity, so the risk of getting a very severe side effect, is related to the dose. So a higher dose gives a higher risk for these very severe side effects. But if you give a lower dose, then you get about 5% of the fibers making about 1% of the microdystrophin. So that is not enough. So we need the higher dose to get enough microdystrophin, but then that's at the risk of these severe side effects. And older patients will have a more severe side effect profile generally because they have a more mature immune system, and also they're older, generally they're heavier. So the dose, which is based on your weight, the dose will be higher. And sadly, one of the 3 deaths was a younger patient. So there's 2 patients who are older, one of 16, one of 27, but the most recent death was a 3-year-old patient. So it's age related, but it's definitely not that older, younger patients are excluded from having these very severe side effects. Now, if we look at side effects, there's 2 types. So there's acute side effects. You give the gene therapy and then you have nausea, liver damage, and with AAV9 also kidney failure, sepsis, and sadly death. But in a few patients, and this happens to all the different types of AAV, you see later side effects in some patients. Breakdown of muscle, rhabdomyolysis, and myocarditis, so inflammation of the heart. And this has nothing to do with AAV. This is an immune response to the microdystrophin, and it's only seen in patients with a large deletion at the beginning of the gene. Now, why don't all patients make this? Because I said Duchenne patients don't make dystrophin. So then you would expect that all of them will, when microdystrophin is expressed, have an immune response. Why doesn't this happen? Well, this is because most patients, if this is the dystrophin, beginning of the protein, end of the protein, and this is the middle domain, most patients have a deletion here. And there's also shorter dystrophins expressed in brain that only include this little bit, which is present in microdystrophin. So this part of the microdystrophin is not new. Most of the patients have a deletion here. So the beginning they will make, it's not stable, but the immune system will be familiar with this. And again, this is part of microdystrophin. So for 90% of patients, the microdystrophin is not new. The immune system will have seen these bits. For patients who have a deletion at the beginning, suddenly this part of the microdystrophin is new because they have never seen it, and then they will get an immune response. So some things that we don't know yet is how functional are the microdystrophins. We know they're functional in mouse and dog models. We don't know how functional they are in humans. These confirmatory studies are still ongoing. What we also do not know is how long they will persist. And that is because we know the microdystrophin is not fully functional. And I mentioned already, in Becker, these pathological processes are also happening. And if there's muscle turnover, you will lose your microdystrophin. So the question is, how long will this take? What we do know is that once you've seen AAV, you cannot treat. So once you've had gene therapy once, you cannot, for now, retreat because you will get a massive immune response. So for now, you can treat only once, but we know that the microdystrophin will not persist forever. The question is, will it be gone after 5 years, or after 40 years, or after 50 years? And that's something that remains to be seen. So now I'm going to go into the last two approaches that target the pathology. So these will not restore dystrophin, these target the downstream effect. And I think you're all aware that corticosteroids are part of the standards of care. They're off-label, but they inhibit inflammation. And these off-label drugs, so there's steroids, there's also cardiac off-label drugs. Again, these are part of the standards of care. The new therapies often don't replace this. But the challenge with steroids is that there's a lot of side effects. And I assume that you are all aware of this. And that's because, well, they can bind the glucocorticoid receptor and inhibit inflammation, which you want, but they also bind the mineralocorticoid receptor, which increases blood pressure. They suppress the cortisol production by the adrenal gland, so you need stress dosing if patients have, for instance, a fracture, or if they are very nauseous and vomit out the steroid. And these steroids can go into the nucleus and activate gene transcription. So there's one wanted effect and a lot of unwanted effect. And then chemists try to tinker. So we have here prednisone, deflazacort, and here vamorolone. What if we slightly modify the prednisone? Can we then get a new drug, so-called vamorolone, that has the wanted effects, but less of these unwanted effects of the steroid? So what does vamorolone do? It still binds to the glucocorticoid receptor, so it still inhibits inflammation, but now it's a mineralocorticoid receptor agonist. So you get a lower blood pressure, which is actually good because Duchenne patients also have heart pathology. You still have adrenal suppression, but this effect where the glucocorticoid will go into the nucleus and have all sorts of effect on DNA transcription, that doesn't happen. So you expect less side effects. Then, of course, the question is, did it really happen? So vamorolone has been tested in clinical trials compared to daily prednisone. So daily vamorolone versus daily prednisone. And so far, the side effects are less. So there's no signs of osteoporosis or growth stunting for now in relatively young patients treated for not that long yet. There is still weight gain, and there is the adrenal suppression. And the efficacy so far is similar to prednisone, but of course we don't know what will happen when you treat for long term, and that's mentioned here. So this drug is EMA and FDA approved for patients in Europe, patients 4 years and older, and the marketing is now being started country by country in the EU. So the long-term effects are not yet known, but there is now this alternative to steroids, and I hope you now understand that it reduces the side effect, but it definitely doesn't have none of the side effects. It still has some of the side effects. Finally, HDAC inhibition, and this is a difficult topic, so I hope, and I will try to explain it in simple terms. So we first have to go into normal muscle regeneration. So in a healthy individual, if there's muscle damage, there's a very synchronized process to target this. You first clear the debris by the inflammatory cells, then you repair the extracellular matrix by the FAPs, so the fibroadipogenic progenitor cells. They make the extracellular matrix, and then the muscle stem cells repair the muscle fiber. Now in Duchenne, because of the chronic damage, this these processes desynchronize. So there's chronic inflammation, the FOPs are overstimulated, so they produce too much fibrosis, and this inhibits the muscle repair. Another thing that happens in Duchenne is that HDAC, so histone deacetylases, are expressed too much. Now, what do HDAC and HET, so histone acetylases, what do they do? You are probably all aware. So at the start of this session, I had cluttered the cord of my headphone. Now it's again a mess. So DNA is also a thin cord. So to prevent that it starts to knot up and break and share and get into a mess, it's wrapped around histones. So histones are positively charged proteins, DNA is negatively charged. So it's wrapped around very tightly. But if it's wrapped around tightly, it cannot be transcribed. And if you need proteins produced, it needs to be transcribed. So HETs add an acetyl group, and then the histones become less positively charged, so the DNA is expelled and you can transcribe it. HDACs remove this acetyl group, so then the DNA is tighter again and you cannot transcribe it. Now, HDAC is increased in Duchenne, and that is because dystrophin binds to an enzyme, nitric oxide synthase. And because there is no dystrophin in Duchenne patients, this enzyme is dysfunctional, and what you get is nitrosylation of all sorts of proteins, and this then leads to HDAC increases. If you don't understand how this works, that doesn't matter. What you have to remember is there's too much HDAC. And because there's too much HDAC, these immune cells are more inclined to perpetuate the chronic inflammation and the damaging type of inflammatory response. Secondly, also, the FAPs are more inclined to produce fibrotic tissue, and the muscle stem cells will transdifferentiate into FAPs because the normal genes that they have to maintain their stem cellness are suppressed because of these HDAC overexpression. So then, if you know that all of this is caused by having too much HDAC, what if we inhibit HDAC? Well, then the immune cells will become more anti-inflammatory. The FAPs will become less fibrotic, and instead they will do what they're supposed to be doing, supporting the muscle stem cells. And the muscle stem cells, rather than becoming FAPs, they will now activate their muscle stem cell genes again and start to repair. So that's the theory. And then again, you can ask, oh, what's the reality? Clinical trials, an early stage trial, they took a biopsy at baseline and after treatment. And after half a year of treatment, the patients had less fibrosis compared to baseline. In a phase 3 clinical trial, they looked at function, and then compared to placebo, the treated patients were quicker on the 4-stair climb, and also the secondary endpoint either improved significantly or there was a trend. Now, it's not that they did better than baseline. The treated patients also did slower than baseline, but as Elizabeth was already saying, the trajectory slowed down. So there were less, the trajectory was less steep than without the treatment. It's now been approved by the FDA in patients 6 years and older. There's no maximum age, and the evaluation with EMA is ongoing. So in summary, you can restore dystrophin in Duchenne patients with exon skipping and stop codon read-through and AAV microdystrophin, but there's room for improvement and confirmatory studies are ongoing. There's now also pathology targeting approaches approved. And of course, what you then can think, well, should we combine these things? Because the dystrophins are not fully functional, so these pathological processes will still happen. So we probably need this combination to have a full effect. And I will thank you for your attention, and apologies for going slightly over, but that's because I try to not speak at my normal speed of talking.
Thank you so much, Professor Aartsma-Rus. We do have just one question to ask because we ran out of time.
Yeah.
But I would forward this question to you because you are the exon skipping therapy specialist. So one person asked if a patient reacts well to exon skipping therapy, do you suspect that they will keep on reacting well in the future on a long-term basis?
Well, that's a good question. So I would expect yes. And I think so. One of the theories at first was, well, if this works, so exon skipping works because the AONs go into muscle due to the pathology. So if it works, then you start making a dystrophin and the pathology will be less. And then you expect, well, maybe then less AONs will go into the muscle. But again, remember, after exon skipping, you make a Becker dystrophin, so there will still be pathology. So for that reason, I expect that it will not get worse. I expect if you respond well, you keep responding well. And I see there's other questions, but I will just answer them in the chat while other people present.
Thank you.
Okay, thank you so much. Thank you for always inspiring talks. And I think there are a lot of other questions that come as well from people. But indeed, we try to keep to the schedule, and you're doing very well now. Thank you so much. The next speaker is Dr. Kristy Iskandar, and she's a pediatrician with a subspecialty in neurology. And she's working at the Department of Child Health at the Universitas Gadjah Mada Academic Hospital in Yogyakarta in Indonesia. And we are extra happy that you are there today because most speakers come from Western countries, high-income countries, and having you as a speaker and with a lot of experience in treating patients in a middle-income country is something we really would love to listen to. And for example, in respiratory care, we often the use of the ambu bag is kind of overlooked, and also the use for other basic aids is overlooked. So we hope that you can show us a little bit about the essentials you use in Indonesia if you have not a cuff assist or non-invasive ventilation at home. And you were the first author on a paper on use of air stacking to improve pulmonary function in patients with Duchenne muscular dystrophy in Indonesia and bridging the gap of care in low middle income countries setting. So we ask you to present on this topic as you have the experience, and we can't wait to hear from you. The floor is yours. Thank you for joining us. Thank you so much.
Thank you very much for your kind introductions. I'm really happy to join this conference, and I'm honored and also happy for being here. Thank you very much. Okay, good day, ladies and gentlemen. Let me share my slide. In this opportunity, I would like to share about the use of air stacking to improve pulmonary function to bridge the standard of care gap in low middle income country. So my name is Kristy Iskandar, and I'm here to represent our team consists of pulmonologists and also PMR specialists from Universitas Gadjah Mada, Yogyakarta, Indonesia. I'm by no means an expert in this pulmonary function, but I make myself brave to represent this study, and most of and also to represent the patients, Duchenne, people with Duchenne from Indonesia. So have you ever heard about Indonesia? So let me introduce Indonesia. Indonesia is a country in the Southeast Asia. It is an archipelago, and it is quite far from the Europe. It may be 12 to 14 hours by plane. Indonesia is the world's largest archipelagic state with over 7,000 islands, and it is the fourth most populous country. So we have over 275 million people. So the first one is China, and then India, the US, and then Indonesia. And the fact is that 41 million people living below the international poverty line of less than 1.25 US dollar a day. However, on the other hand, we also the country with the 10th largest economy in the world by purchasing power. Why this can happen? Because there's a large gap between the very poor and the very rich in Indonesia people. We also have a very beautiful natures and also cultures, and you can come anytime in Indonesia and you will feel the warmth of Indonesia. We have always have sunny days in all over the year. So one of our biggest temple in Indonesia is called Borobudur. It is a Buddhist temple, and it is very huge. It is built in 800 AC, and one of the Duchenne boy is very strong to make it on the top. His name is Maxim. I think he was 22 years at that time, and he's from Belgium. And he was very kind to receive our invitation when I met him in Amsterdam in the DMD Expert Master Class that was organized by Trade and MD. And I don't know, is it Elizabeth at the background? I'm not pretty sure. So he and his father came to Indonesia to give speech and encourage people with DMD in Indonesia in the DMD Awareness Day on September 7, 2019. So yeah, I've told you that Indonesia is the fourth most populous country with over than 275,000 people. So we also have high birth rate of 5 million babies a year. So with the incidence of 1 in 3,500 to 500 to 5,000 male newborn, it is estimated that 500 to 700 DMD babies will be born each year in Indonesia. So I think the burden of DMD is high in our country. And we have known that the standard of care guidelines for DMD has been published in 2018 as the revised version of the 2010. And although the management has been roughly written, but the implementation is not that easy in our country. For examples, for the diagnostic, the genetic testing has been shown and recommended as the first testing after the serum creatinine kinase to diagnose the Duchenne muscular dystrophy. However, in our country, it just recently, I think the first time is 2018, we can do the DMD genetic testing in Indonesia. And our center currently is the only center that can do the DMD genetic testing using MLPA studies. And now we are taking care of 159 patients. But as you can see, I think there's a lot more DMD patients in Indonesia that we cannot reach and we cannot diagnose. And because our country is an archipelagic state, that it is quite hard to and difficult to reach the people far from our center. Previously, the genetic testing is also not covered by our national health insurance, and it is not affordable for the majority of our people. But luckily, the Indonesian Ministry of Health commends the genomic initiative in 2022. And we are lucky as our center is appointed as the genomic hubs for rare disease and genetic disorder, including Duchenne muscular dystrophy as the first disease of to be studied. And Professor Ishikawa from Hokkaido University, she has appointed that the DMD survival rate has been doubled because of the invention of ventilation or a non-invasive ventilator from 1991. We can see here that the age at death in Duchenne muscular dystrophy patients is around 20 in the second decades, and after the ventilation, it doubled more than the fourth decade of life. So we can see the importance of ventilation in the MD survival rate. Yeah, so respiratory complication is the major cause of morbidity and mortality in people with Duchenne muscular dystrophy. As we know that in Duchenne, there is respiratory muscle fatigue, mucus plugging, atelectasis, pneumonia that will end up in respiratory failure. That's why monitoring of respiratory muscle function to timely use of lung volume recruitment, assisted coughing, and assisted ventilation. The first is nocturnally, followed by daytime or 24 hours, is really important to combat the morbidity and prolong the survival of rate of people with Duchenne. Yeah, as we know, the respiratory devices in the MD is the mechanical insufflation and exsufflation machine, and also non-invasive ventilator or BiPAP. That is easy to access in developed countries such as Europe and also the United States and Japan and other developed countries, but it is still out of reach of us in Indonesia because of the price and because our national health insurance does not cover this kind of machine. We also know that indication for respiratory devices is when the spirometry results show the forced vital capacity less than 60% of predicted, or an assisted coughing is needed in the non-ambulatory. So these respiratory devices usually is needed when the in the non-ambulatory stage, as yesterday has been mentioned in the respiratory lecture. So the lung volume recruitment is needed when the forced vital capacity is less than 60% predicted, while the assisted coughing usually need in the late non-ambulatory phase, where the FVC is less than 50% predicted and the peak cough flow is less than 270 liter per minute, or the MEP is less than 60 centimeter H2O. And the assisted ventilations is also needed nocturnally if there is a sign or symptoms of sleep hypoventilation or other sleep disordered breathing, abnormal sleep study, and also other parameters by spirometry, oxygen saturations, and also carbon dioxide pressures. And additional daytime assisted ventilation is needed if, despite nocturnal ventilation, the saturations of oxygen daytime is less than 95%, or the CO2 is more than 45, or the symptoms of awake shortness of breath are present. This respiratory device is very important that it can increase the quality of life, prolong survival, and also decrease pulmonary complications. However, can us in Indonesia afford this device? As you can see here that our GDP is very far from the United States or also in the European Union, that we have financial constraint to afford this kind of machine. I think in 2018, Professor Masafumi Matsuo from Kobe University, Japan, he brought by himself 12 ambubags from Japan in his own carriage to Indonesia, to our hospital, and he taught us about the affordable, probably alternative to the sophisticated machine to help the pulmonary function in Duchenne patients. So at that time, we do small studies comprising of 8 Indonesian DMD patients, and we do the baseline pulmonary function measurement using spirometry and do the air stacking with resuscitator bag, combined method with chest compressions, and do the peak flow measurement and do another assessment. So this is the methods of air stacking and combined methods you can see here. Thank you to Dr. Dian from Universitas Pajajaran and Hasan Sadikin Hospital. So this is the air stacking methods. We only need the ambu bags, which is very cheap, and also fast face mask. And you can compress the face mask, the ambu bag into the person, and we can see here that and this is the combined methods by compressing the ambu bags and then followed by manual chest compression, and we can see that the flow is much more higher compared to only air stacking. And this is the manual assisted cough. So we ask him to exhale and inhale, exhale and inhale, and take a deep breath and then cough. And we can also help the patient to cough and push using Heimlich maneuver to make the cough more powerful. Yeah, our patient characteristic is about 13 years old, and the genetic deletion test was positive at that time. At that time, we cannot do the sequencing, but now we already confirmed that all the 8 patients has the mutations in the DMD gene. The 2 of them is the point mutation. Previously, we cannot do the sequencing. And scoliosis is there in the patients. The mild 2, moderate 3, and severe is 3. And at that time, the immunization is not done to all of the patients, but now we already have our patients do the immunization before the steroid introductions. And we can see here that in our patients, the FVCs are all low, less than 50% predicted. They have restrictive pulmonary function, and awake respiratory status showed better result than nocturnal respiratory status as we predicted. And we can see here that our patients need lung volume recruitment and also assisted coughing at that time. And assisted ventilation is also needed by some of the patients. And we can see here that an assisted cough is only produced 160 TCF value, but after we do the manually assisted exsufflations and also air stacking and also combined technique, we have the cough is much more better than an assisted cough. And the air stacking also effective in increasing the peak cough flow with only manual assisted air stacking or also combined methods. Country. However, this might not exchange the need of machine in further stage of non-ambulatory conditions, such as the late stage in which the hand cannot reach, cannot lift. I think we still need the machine. And this air stacking is affordable, readily available. Yeah, there's another assistant need, but it doesn't have to be a special person or a doctor. It can be a person or a caregiver that has already trained. And of course, there is no electricity needed and no burden equipment needed. So maybe air stacking can be can be used, especially when there is no electricity or there is some problem in the battery of the machine and in other conditions. Thank you very much for your attention. Please come to Indonesia when you have time. Thank you.
Thank you, Dr. Iskandar. I hope you hear me well. So
Yeah.
now let's get into a Q&A session. I really enjoyed listening about a different approach in care, different things to kind of struggle with. It's how wonderful that you're doing testing in your center and you're the only one there. We had an interesting presentation yesterday as well about respiratory support and use of telemedicine. Do you yourself use any kind of telemedical instruments as well? For example, on courses or something?
Yes, we have telemedicine, and especially because we are an archipelagic country, so a lot of patients live outside our island. But for the spirometry or pickup flow measurement, we haven't done in telemedicine options, but maybe we can learn from yesterday's lecture about how to use the telemedicine and also with pulmonary function measurement.
And how often do usually patients come to your center to be seen?
It's once a month.
Once a month for the respiratory training?
Oh, no.
No.
For control.
Okay.
Yeah. But for respiratory, usually it's once a year. And if the pulmonary functions getting worse, maybe half a year once.
Yes. And I imagine the wide population is kind of an issue to reach all the people. Do you have any help reaching the population and offering the testing, gene testing?
Yes, so yeah, because of the Genomic Hub released by our Ministry of Health, they also help us to coordinate the hospitals under the Ministry of Health to send the suspected Duchenne samples, blood samples to our center. But it just started. So previously we only have like a Duchenne Awareness Day, and we also have advocacy like yours, like the World Duchenne, that we hope we can get as many as Duchenne patients to have genetic testing.
There is also a question if you perform polysomnography in your center. So a sleep study, if you do sleep
Yes.
study in your center?
Oh, no. So we did the study only for this paper. Yeah, but we don't do the sleep study in usual practice. But yeah, I think it is very important also because of the Duchenne patients. 30% of them have intellectual disability that is difficult to do the spirometry. So I think yeah, we want to increase our standard of care, like Elizabeth said, that it's not only the fancy new drugs, the molecular modifying drugs that we cannot reach, but I think the standard of care itself is already increasing the survival rate of Duchenne patients.
And last question here from the audience, if maybe yoga breathing exercises can help improve health of lungs.
Oh, and that's very interesting. I haven't heard about that, but I do really want to study and learn if yoga breathing also can help our patients. Thank you.
Right. Thank you. And please look at the Q&A session as there is a contact for you. Someone wants to connect with you. And now I give the floor to Elizabeth and to the next speaker. And thank you again, Dr. Iskandar.
Thank you. Thank you very much.
Yeah, thank you so much. It's really amazing to hear from you. And also, I mean, I can imagine that you have to take a lot of hurdles clinicians in other countries don't have to take. So we really would like to say, keep up the good spirit and spread word that also with less equipment, you can do a lot. Thank you so much.
Thank you.
And then our next speaker is Dr. Zvonimir Bebic from the Children's Hospital, Colorado. And he's an anesthesiologist and a pain medicine physician. And for the people who follow the Duchenne Care Conference since the beginning, they know that pain has been on the agenda before. Professor Susan Epcon presented in, I think it was 2022, about the diagnostics of pain and a serious problem in Duchenne, and especially when getting older. This year, we are very happy to have a speaker about the interventional and medication management of pain in Duchenne muscular dystrophy, recommended by the same Professor Epcon, included in our earlier conference. So we are really happy to have you here, and we can't wait to hear your presentation. The floor is yours. Thank you.
Thank you very much, Elizabeth. I'm going to share my slides. Admittedly, this is a very large topic, and so really the presentation is more a combination of some strategies to think about, as well as things that we have found in our own experience in treating not just patients with muscular dystrophies, but also those with other physical disabilities such as cerebral palsy, and also end-stage cancer and palliative pain. More than anything, I think the presentation is meant to just pique some interest and give you some introduction into possible treatment modalities. And then if it's helpful, I'm happy to answer any questions or even offer my contact information if people have any other questions about additional pain management strategies. So I have no financial relationships with any commercial interests, but I will be mentioning two formulations of buprenorphine later in the talk. So yes, two formulations of buprenorphine that are, to my knowledge, not only under brand name. And so those will be mentioned, but otherwise, no other relationships. These are the contents of the talk. A couple of things I do want to highlight before we actually get into the medication intervention management is going to be what pain actually is, how we in the pain management world conceptualize assessment and thoughts about pain, and then finally going into medication management and then interventional options for patients with Duchenne's. So our clinic is a multidisciplinary clinic, which means that we collaborate with pain psychology, different therapists, social work, nursing, as well as other specialties. And although it seems a little bit redundant, our primary goal is pain reduction. However, it doesn't always happen right away. And so sometimes we accomplish pain reduction through doing things that actually may inadvertently cause patients pain, such as physical or occupational therapy, functional restoration, and interventions. Ultimately, the goal of this is to reduce pain and suffering. But more importantly for us, we want to establish quality of life measurements and goals for patients so that we can actually work within that framework and see what their goals for a healthy and meaningful life actually are. So IASP is the International Association for the Study of Pain, and they've had a pain definition for quite some time, which was recently revised in 2020. And there's a couple of very important aspects to this revision, but the way that pain is defined is an unpleasant sensory and emotional experience. And what's important here is that the two are linked forever and always. It's both sensory and emotional, meaning that you can't have a pain experience without there being an emotional experience. I can't come home and stub my toe and not feel something related to stubbing my toe. And the context of your emotions, the day, how you've experienced it, will actually affect how you interpret that pain. So if I come home and I've had a good day and I do that, it may not bother me as much, especially if I have other things to distract me or more important things on my mind. If I've come home, I've lost my job, I'm not having a good time, and I stub my toe, then that pain experience is going to be that much more amplified and actually associated with the emotional aspects that go along with it. The other thing that's important is that pain is an experience, meaning that oftentimes, particularly in the medical world, we look at pain as more of a nociceptive phenomenon, and nociception is not something that equals pain. It's really just transduction of sensory signals into something that the brain can process. but it's this transduction plus the processing that goes on in the brain, plus or minus the modulation of the spinal cord, that altogether we look at as comprising the pain experience for patients. So when we say pain, this is actually what we're trying to address for patients. And the other thing that's important about this slide is that there may or may not be tissue damage. And so imaging ESRs or CRPs may not be helpful in diagnosing pain. Sometimes provocative maneuvers need to be done. Sometimes we just rely on the subjective experience of the patient themselves. It's not always that all pain is treated with medications or interventions, but all pain reports and experiences need to be appreciated and validated. In addition to this definition, there are 6 extra points that were added by IASP, and really just confirming those things that we mentioned. So pain is a very personal experience, and again, is influenced to varying degrees by biological, psychological, and social factors, meaning different patients have different pain thresholds, tolerances, ways that they process. Psychological state, emotional state can very much influence how pain is processed. And as well as social factors, how much support patients have, both at home and in their social lives, all help to either reinforce, attenuate, or augment the pain experience. And then more importantly, pain and nociception, as we said, are different phenomenon. You cannot infer pain solely from activity in sensory neurons, meaning there's no specific test per se that we can use to rule out whether a patient has pain or not. So looking at an MRI and saying, well, that should be painful, doesn't always correlate, as there are many patients with MRI findings that look like they should have either discogenic, vertebrogenic pain, joint-related pain, and they don't, and vice versa, where others have no active inflammation but still have pain and do respond really well to either medications or interventions. As far as pain physiology, I won't go too much into depth with this, but just to suffice to say, nociception is really, again, just the transduction of noxious stimuli, and the 3 main noxious stimuli are heat, cold, chemical, or pressure and crush. So those are the things that receptors in the neurons will respond to, and these are high sensitivity or high threshold receptors, meaning that a warm stimulus should not cause pain. A little bit of movement in the joint should not cause pain, but over time, if these sensory things are experienced constantly, the threshold of the neurons can actually change over time, and therefore things that generally would not be expected to cause pain start causing pain. The relay of those signals from the periphery goes up to the spinal cord, and that can either be attenuated or augmented at the spinal cord. There's a lot of top-down inhibition, mainly through norepinephrine and other neurotransmitters, and you'll see later why we use certain medications to try and mediate or modulate this attenuation. And then finally, there's interpretation of some of these experiences and signals, and that's really become some of the focus of restorative pain management in our clinic. What's important, I think, here is that particularly with patients with muscular dystrophy, cerebral palsy, ones that are wheelchair bound for long periods of time, oftentimes we start to conflate nociception, the presence of or not with either having pain or not. But remember that these patients also do have their own histories, their own experiences of pain, social reinforcers of pain, and so these need to be taken into account as well. How their parents or loved ones have reinforced whether something is very serious or not very serious will either make pain worse for them or not as bad as it can be. I'm not going to go through all these, but these are all the areas in the pain that are involved, in the brain that are involved with pain. And you can see that any of these areas either can be intensified or attenuated based on pain experience. So the more pain you have, the more emotion that's attached to it, the more some of these areas in the brain may, quote unquote, light up. And as a result, may reinforce chronic pain, suffering, and behaviors. And so when we talk about pain, again, these are all the areas that we are still trying to address. This is just a little review of some ascending pathways, but you can see pain signals or noxious signals go through the dorsal root into the dorsal horns, and then cross over up the corticospinal and spinothalamic tracts when they get to the thalamus, and then are later sent to different areas of the brain for processing. The assessment of pain is very important. Oftentimes for pain, we will do physical assessments, but a good and careful history can give you a lot of information. In patients who are old enough, usually around 3 years old, who are cognitively intact, a self-report can be elicited. Now, they may not be a numeric rating scale or very specific, but a 3-year-old should be able to give you a self-report. From about 8 on, a VAS scale or numeric rating system can be helpful for these patients. And then a mnemonic that we often use for the HPI, the history of present illness, is old cards. So these are some of the characteristics that you'd want to know about painful episodes or symptoms. So when it started, where it is, how long it goes on for, what the character is. Is it more neuropathic, so burning, tingling, itching, or is it more dull, which could, and not well defined? Is it more abdominal? This could be more of a visceral pain. Or is it more well-defined, achy, and in a peripheral area, so more like somatic pain? And then any other symptoms associated with the pain as well. Specifically related to Duchenne's patients, extra consideration we give to activities and positions that provoke pain, so such as transfers to and from wheelchairs, diaper changes, moving the hips in certain ways, lifting, things like that. Does lying sideways provoke the pain, or lying recumbent? Are some positions more comfortable or not? So all these things will help us sort of clue into areas that we may want to consider intervening on. And then as well, before we offer any sort of medications, and this goes for all pain patients, before we offer any medications or interventions, we want to make sure that we're optimizing things that can be optimized. For instance, absence of sores. Are the chairs comfortable, appropriately fitted assistive devices? Is their sleep good? Is their diet good? Are there any mood disorders or things like that that need to be addressed that may be contributing to pain or being misattributed to nociceptive pain? Many common pain symptoms observed in our clinic, particularly for patients that are in wheelchairs for long periods of time, and also those that are in the ambulatory phase but progressing to the early non-ambulatory phase, are low back, pelvic, and lower extremity pain. So low back, specifically low lumbar. So there's evident or components of myofascial pain, components of facetogenic, vertebrogenic pain. There seems to be less discogenic pain, though I'm sure that it can occur. Pelvic pain, most commonly we find is associated with weak gluteal or supporting muscles and tendons in the area. So specifically SI joint, greater trochanteric bursa pain, hip extensor and external rotator muscles. And then lower extremity pain oftentimes is related to ischial bursitis, just from prolonged sitting without appropriate offloading. And then also knee pain, and this can be either knee pain from fat pad irritation or tendinopathic pain. Most commonly with pelvic pain, again, is arthralgic, myalgic, and tendinopathic. And then very or less commonly is neuropathic pain. Other considerations before we're trying or starting any medications, obviously cardiac, avoiding medications with cardiac depressant or arrhythmogenic effects, and we will discuss that with some of the opioid medications and antidepressant medications that are used. We do want to limit or at least be careful in our choice of medications that cause respiratory depression, such as stronger opioids, or any muscle relaxants that may predispose to relaxation of the upper airway, and therefore any sort of obstructive airway issues. And then any anesthetic precautions. If we are planning on taking patients to the operating room, what is the ideal anesthetic for patients to make them comfortable during the procedure whilst avoiding any potentially triggering anesthetics or overt sedation. And then as well, as I mentioned earlier, what kind of quality of life and overall goals for the patient. So if they do want to avoid over sedation, let's say they're very sensitive to medications, maybe we jump to interventions a little earlier. If they're not fit for anesthesia, or they outright refuse interventions, or they're not even possible given certain anatomic issues, how can we choose medications to limit a lot of sedation and cognitive issues associated with them. So as far as medication management, many of these are very familiar to everyone, I'm sure. I'm just going to go quickly through a lot of the ones that we use most commonly in the clinic. Acetaminophen and NSAIDs are probably the most common and first-line medications that we will use, and there are certain ones that we do prefer given their safety profile and ease of use. Neuropathic and anticonvulsant medications, again, a little less likely or less commonly used for pain in our clinic, though we do use them. I'm not going to talk too much about muscle relaxants today since we use them in very select conditions. SSRIs, SNRIs, specifically for some of the top-down inhibition of pain, and also for patients with any concomitant mood disorders. Ketamine is an emerging formulation that we've used in the outpatient world, as well as the inpatient side, and there are certain formulations we like to compound for certain patients. Opioids and then steroids, and in this talk specifically steroids that are injectable and not oral formulations. So acetaminophen, really well tolerated in patients and can be very safely administered through all age groups. Obviously, care must be taken in patients with liver function issues, but typical doses for pediatrics are anywhere between 10 to 15 milligrams per kilo per dose, every 4 to 6 hours, and up to doses of 3,000 to 4,000 milligrams per day. I put a range on the upper limit mainly because I tend to be a little more conservative with these sorts of medications. And so if we don't need to use more than 3,000 a day, I typically stop it around there. Oftentimes we will either add these in conjunction with NSAIDs or other opioids if we are using them. And then for adult patients, again, less than 60 mg per kilo per day for children. These can be safely administered with NSAIDs, and again, specific CYP inhibitors or inducers are 2D6 and 3A4 because many of the medications we use in pain management are actually metabolized through these cytochromes, and so care must be taken when administering these sorts of medications. So other medications that we'll be talking about, so codeine, hydrocodone, so certain opioids, tramadol, and some antidepressants are actually metabolized through these pathways. NSAIDs. So whenever we're thinking about positioning NSAIDs for treatment, we think about duration of treatment. Is this going to be something that's more acute, so less than 2 weeks? Is the pain going to be constant, meaning all the time, daily? Or is it more episodic and we need to pre-treat certain position changes? What is the risk of gastritis? Are they on other medications? Do they have other underlying conditions that predispose them to that? What is their risk of kidney injury in terms of other medications or underlying kidney issues? And then what kind of route of administration do we have to choose? And then also bleeding risk. It's not commonly known, but not all NSAIDs confer the same bleeding risk as other ones. And so that can also be a factor in selection. Normally, when we position NSAIDs, we will start with regular dosing for 1 to 2 weeks, and then we'll use it PRN thereafter. We always make sure we ensure adequate hydration. And then for patients on regular dosing, meaning those that will be using it expectedly for more than 3 months, we will get renal function panels with sodium potassium as well every 3 to 6 months. Generally speaking, COX-2 selectivity should confer a lower risk of NSAID-induced gastritis, though patients can also be placed on a PPI, which can also reduce that to the same level. And NSAIDs do vary in their level of COX-2 selectivity, and so those that are more COX-2 selective, your classic ones would be like a celecoxib or Celebrex, would be sort of the highest selectivity, and there are others on the very low end of the range, such as ketorolac, which are very non-COX-2 selective. This is just a very brief graph, but if you look online, you can easily just Google COX-2 selectivity graphs and NSAIDs. But these are the ones in order of least to most, and you can see Celebrex at the top there, celecoxib, and Toradol at the lowest. A couple of things to note about each of these. Totolac and meloxicam do not have any platelet they do not inhibit platelet aggregation, meaning that they don't really confer any additional bleeding risk. And if the patient is on them, we actually don't have a problem with them going to procedures or surgeries while being on these medications. Diclofenac is interesting because it does have a topical version available, and it's also very useful for headache management. So these two, between meloxicam and diclofenac, are also very good for for COX-2 selectivity. Ibuprofen is very easy to administer because it does come in a liquid solution as well. We tend to prefer meloxicam and diclofenac mainly because of the COX-2 selectivity. And really the main concern for me is if it's more episodic, we'll pick diclofenac, and if it's more constant, then meloxicam. Gabapentinoids, centrally acting medications in the dorsal horn. They also do act on an NMDA and some inflammatory cytokines, and then do affect some top-down inhibition. The doses for neuropathic pain are quite high and often very prohibitive. Most commonly, though, we will be using them for sleep, actually. You can consider switching to pregabalin if they're having any dose-related issues or excess fatigue. For most patients that are started on gabapentin, this will improve within 1 to 2 weeks. As a general pain medication, we don't often start it just because the doses needed for it are quite high. But having said that, though, for sleep, it's actually quite a good medication, owing to the very low dose that's needed, but also very minimal effects on sleep architecture, particularly relative to other medications that we use on sleep. So if we are going to be starting a medication for sleep, we really don't want it to be a medication that's going to be not giving them restorative sleep per se. Care should be exercised with other sedating medications. However, a lot of the studies that looked at gabapentin and having issues with respiratory depression were done in older patients and those on opioid therapy as well. I'll pass this slide, but gabapentin, if you are going to higher doses, pregabalin tends to be a better option given its consistent bioavailability. Gabapentin seems to decrease over time, whereas pregabalin doesn't, and it's a very easy conversion rate. You can also Google this chart online, but the conversion is about 1 to 6, and so we can easily convert from pregabalin to gabapentin and back and forth if we need to. Antidepressants, I'm just going to focus on duloxetine because that's the one we most commonly use, but the purpose behind this is treating or augmenting some of that top-down inhibition we're using norepinephrine in the spinal cord. And especially with patients with comorbid anxiety or depression, this can be helpful as well. Usually doses of around 60 milligrams a day are needed for this, and we'll start an initial dose of about 20 and increase that weekly. For about 10% of patients or so, duloxetine can be activating, and so we'll position that in the morning as opposed to the evening. I'm going to briefly touch upon ketamine, but we do use it initially for inpatient infusions for patients at subanesthetic doses, usually around 0.1 to 0.5 milligrams per kilo per hour. But for select patients, we do use it as a nasal spray or oral medication. We started using this mainly in patients with burn-related pain or contractures, and as well as in our epidermolysis bullosa patients. But in some patients who have significant respiratory distress, ketamine does not cause any respiratory distress, depression, so it is a good option there. The nasal spray is a much faster route, whereas the oral route is a much more stable route. In patients with cardiomyopathy that's quite significant or progressed, care needs to be taken with higher doses as ketamine can precipitate cardiovascular collapse in patients with low EF. The old adage in opioids is to start low and go slow, but we can use these safely in patients with Duchenne's. I like to start with tramadol mainly because overall tends to have less of a respiratory depressant effect, less sedation, and also is a very weak opioid agonist. And so if we can start with weaker medications, we do like to do that. As well, there are some neuropathic properties associated with tramadol. So if you are considering an opioid for neuropathic pain, this tends to be a good choice. Starting dose for these are usually around 0.5 mg per kilo approximately. They do come in a liquid form, but it is typically hard to come by. The max dose for the day is about 400 milligrams, and that's divided into QID dosing. We typically will start at either BID or TID dosing, and we'll limit it to 200 milligrams or less in patients on antidepressants just to limit serotonin toxicity. Buprenorphine is an emerging one that we like to use. There is a ceiling on respiratory depression for buprenorphine, which is very helpful and also can be used for acute and chronic pain. There are some reports about QT prolongation of buprenorphine, but when it was tested in a couple of randomized trials, there's not been shown to be any. So for patients who are either prone or at risk of arrhythmias, buprenorphine can be a good option. The two formulations we like to use are Butrans patches, which are transdermal and last about 7 days, or the buccal patches, which are Bebic, and those can be used on a Q12 basis. For patients on longer standing therapy for these, LFTs do need to be monitored for longer term use. These are the two formulations we mentioned, and the low end of the range, so the 75 mic and 5 mic patches respectively, are about equivalent to less than a 30 milligram per morphine equivalents per day, just to give you some reference. The website for these patches actually will give you a conversion calculator that you can use to estimate. And then finally, interventional pain management. So on the left is phenol innervation or neurolysis for genicular neuralgia, and on the right is an example of a sacroiliac joint injection. So most common injections we do are for peripheral joints, tendons, and bursas, and it's always a combination of a local anesthetic and steroid. And these are these can either be the treatment or it can be a diagnosis. So for instance, for patients with SI joint or suspected pathology, the injection is actually the diagnostic tool. Sometimes we will use phenol or radiofrequency ablation for peripheral nerves when we want longer term relief, or in certain joints when steroids are either prohibitive or not lasting long enough. The anesthetic phase is the phase that usually happens right after the injection. So if the patient gets relief right after the injection, but doesn't last afterwards, it at least tells us that where the area injected is the area that's contributing to pain. If they don't get long-lasting relief, we'll usually wait for about 2 to 14 days for the steroid to take effect. And then after that, if there is relief, then that can be positioned as one of the therapies going forward. For any peripheral steroid injections, ideally, we like to see about 4 to 6 months of reduced pain or improved function, and mainly because we want to avoid repeat steroid doses over time, but also for joint degeneration can be a problem later on. Main areas of pain, I'll have them listed here. You can go over them at your own leisure, I think, since we're running out of time. For each of these, there are very specific provocative maneuvers that can be done. Oftentimes in patients who are wheelchair bound, these maneuvers aren't very helpful. And so oftentimes patients pointing to specific areas, palpation, and even just taking them through some of the motions is enough to elicit and give us suspicion. However, common things are common. And so SI joints, greater trochanteric bursa, intra-articular hip injections, and then intra-articular knee and fat pad injections are probably the most common areas that we do inject patients with Duchenne's. And again, just be aware there may not be radiologic findings, so it may not be something you can go on. Oftentimes, if you suspect an area is painful, your imaging modalities may not be useful for you, so go ahead and consider injection. These can either be done in office by an anesthesiologist or PM&R-based pain physician, or in a procedure center with minimal sedation. I won't go over the summary, I'll leave that to you, but I will open up for any questions if there's time. Thank you.
Thank you. Thank you so much for your presentation. I mean, we are really lacking information about this subject in the Duchenne field, and maybe also in other fields, but at least also in Duchenne. So we are very happy with your presentation, not only now, but also to have these materials to use later for people who have to learn more about the pain and management of pain in Duchenne. So thank you so much. Given the time, we would like to go to the presentation of Professor Duboc. And if there are questions, but there were no questions so far, maybe we can send them to you and you can answer them at another moment. Thank you so much for making the time for us. Thank you.
Thank you.
And then we now go to Professor Duboc. And this is kind of a long story. We started, I think, in '97 in Rotterdam with the first European conference. You were one of the presenters there. And I think it is really a beautiful story to hear how you, during your long career, made a big change in the lives of Duchenne boys and men, not only by caring for your own patient, but also by being the man behind the preventive use of ACE inhibitors in Duchenne, which are now the part of the standards of care, although still off-label. you didn't stop after the RCT, a randomized controlled trial, but continued with an open label study, and ultimately that had a positive outcome, which led to the use of it now. So recently we used this story as an example that we may miss more possible treatments for Duchenne because RCTs are short and the drug approval is not based on long open label trials. So thank you so much again. Happy to have you here and happy to learn from you again what is beyond ACE inhibitors. Thank you so much. The floor is yours.
Well, it's a pleasure for me to do this presentation. As Elizabeth mentioned, it was the first story in Rotterdam was very interesting to present our initial results, but now we can say that some of these results are applied in the care of patients suffering from Duchenne muscular dystrophy. Can I have the next slide, please? It was difficult to recognize that the heart was a problem in Duchenne muscular dystrophy. It takes finally a long time in the natural history of this disease. But in the 80s, something like that, it was accepted that the heart was involved and could have some clinical consequences in the progression of the disease. I mentioned these pioneers in this field, which was Negro and Perloff, who first mentioned that the heart, we have to take care of it, not only of the spine and not only of the respiratory problem, but also of the heart. And next slide. Because it's very difficult for a patient who is suffering with disability to express the first manifestation of heart failure, of low cardiac output. And this is the reason why the heart problems was, during a long period, not completely accepted as a major problem. But now it's clear that it is a major problem. Next slide. And it, for the DMD, for other diseases suffering from the, for other neuromuscular disease, but particularly in DMD. Next slide. Because finally, all the patients will develop a left ventricular dysfunction and they will die in quite half of the patient will die from a heart problem and heart failure. And what is particular, when we know this natural history of the disease, we know when you have this mutation, your heart will be involved. You will develop cardiomyopathy. And it's the reason why, besides the curative treatment, we wanted to try to give a preventive treatment before the appearance of the left ventricular dysfunction with the tool we use to evaluate the ventricular dysfunction. This tool is essentially echocardiography and angiography. But this tool demonstrates finally that we can have very early in the time course of the disease left ventricular dysfunction. Next slide. You have also now MRI, which is possible to indicate that finally you can have some isolated fibrosis without major decrease of the left ventricular ejection fraction. And finally, you can have infraclinical, infra-echocardiographic heart involvement. And the heart, it begins the heart involvement in terms of cells much more early than we thought before. Next slide. It's the reason why we tried this first. I think it's the first control trial, as well in Duchenne muscular dystrophy, but in orphan disease in general. In orphan disease, as mentioned Elizabeth, Usually we have only observational trial based on pathophysiological consideration, but it was not widely accepted to perform at this period control trial versus placebo in an orphan disease as Duchenne muscular dystrophy. So we proposed to treat young patients before the age of 13, and the majority was 10, 9, 5, with a treatment which is not indicated, because it is indicated in heart failure, left ventricular dysfunction, but it was not the case because it was normal. And to propose two groups, a placebo one, a classical control trial, placebo versus double-blind pyrindropyl, which is an ACE inhibitor, an inhibitor of the enzyme which transforms the angiotensinogen on angiotensin 2, which is something deleterious for the vessel and for the heart. Next slide. And it was after 60 months of follow-up. In black is the patient who were initially to placebo. In red, the patient we were on ACE inhibitor. You can see that the left ventricular ejection fraction, which is still a substitution criteria, but it is a very clinically relevant substitution criteria because the prognosis is very linked to the left ejection fraction. And you can see that quite no patient who receive very early during the time course of the disease developed left ventricular ejection fraction, the decrease in left ventricular ejection fraction. Despite this, the other who receive initially placebo have a decrease in their left ejection fraction. And next line, we continue to follow the cohort of this patient, and we can see that there was a decrease in mortality with a patient who received in early period of the time because of the disease ACE inhibitor. Another lesson of this trial that we could not include 20% of the patients selected because already before the age of 10, there was a significant ejection fraction decrease viewed by echocardiography. This was a preliminary trial. Next slide. And now we have with Karim Wabi, we have analysis, a very big registry data of our patients in France and in Europe. Next slide. And as you can see, the patient who received, it's a registry of about 700 patients who received initially ACE inhibitor. There is a lower mortality and also a lower, very significant decrease of hospitalization for heart failure. Not modified, it is the respiratory dysfunction, but this was not very surprising. Next slide. So the first message for the doctors in charge for this patient is to give this preventive treatment early in the time course of the disease. We will discuss after at what age it seems to be the age to begin this treatment to increase the benefit, because earlier is the treatment, longer is the benefit. Next slide. This was also after observed in observational trial by an early treatment for the Becker muscular dystrophy, is the same topic. Next slide. So this is the preventive treatment. Is there also other preventive treatment for the cardiac aspect? We can discuss also the interest of beta blockers and the interest of eplerenone. The other aspects, the other treatment are the curative treatment in front of left ventricular dysfunction, in front of heart failure, but this is quite the same that in the general cardiology, I would say the classical cardiology, it's the same treatment. So next slide, concerning when to start the ACE inhibitor. I think 10 years old is, for me, and for many groups, clearly established, and probably 7 years old could be the best period to be sure to have a good benefit for this patient, and many teams now start ACE inhibitor at 7 years old. Even in the absence of left ventricular dysfunction, slow minor. But the real question is, would it be interesting to start it earlier, since the age of 5 years old? Why not? This is to be, we have treated some patients very early, and what we can say is that there is a good tolerance. The difficulty is the observance. Next, at this age. Next slide. So, in real life, it's what we observe. We give ACE inhibitors, and this is associated with a decrease of left hospitalization for heart failure, but also a decrease in global mortality. So there is a specific effect also on the skeletal muscle, which is clearly demonstrated experimentally. And the next slide, Chamberlain said it finally inhibits the TGF-beta in the skeletal muscle, which is something which inhibits the muscle regeneration. There's also a benefit on the muscular capacity of the patients. Next slide. Concerning the other treatment that can be given, it is also the eplerenone. Eplerenone is a sort of diuretics, but which has also specific antifibrotic properties on the heart muscles. All these kind of diuretics, which are called the anti-aldosterone, have this effect, specific effect. They limit the absorption of the salt, but also they have antifibrotic effect. And it's the reason why the group of Linda Krebs have done this control trial also using eplerenone, and she focused also only on substitution criteria, which is the decrease of the left ejection fraction. Next slide. And this is been done in addition of ACE inhibitors. And you see the patients were more than 7 years, and quite all patients received the ACE inhibitor. Next slide. And as you can see, there is a weak preservation of the left ejection fraction in the group of eplerenone. It's quite normal that and it is significant in terms of statistics. It's quite normal that the preservation is weak because it is only 1 year of follow-up, something like that, and also because all the patients received ACE inhibitor. It means that they also take the great benefit of ACE inhibitor. So when you add something, the benefit is significant, but it's much more moderate than before because it's an addition of on an important effect of ACE inhibitor. And so we can recommend also the use of eplerenone in association of ACE inhibitor to prevent, it is a prevention, to prevent the occurrence or to delay, I would say, the occurrence of left ventricular dysfunction. Next slide. What about the beta blockers? Beta blockers, can we use it in terms of prevention? Next slide. Well, there is a very strong rationale to use it, to propose it, because in this disease there is frequently tachycardia. There will be, it is a drug which has been demonstrated very efficient in the heart failure, and also it's well tolerated. We have some observational trials which demonstrate a benefit of beta blockers. The randomized placebo-controlled trial have difficulties to demonstrate a specific effect, but the majority of these trials have some methodological consideration which are not sufficient for me to say that it's not necessary to use the beta blockers. So, in fact, when you observe a mild decrease of the left ejection fraction, you will have to add the beta blockers. And I think, in general, now a patient suffering from Duchenne muscular dystrophy, which is 12 years old, have ACE inhibitor, eplerenone, and the beta blockers, the small dose. Next slide. So the curative treatment when you have heart failure is the same that in the general population. You will have the association of spironolactone, neprilysin inhibitor, which are classical drugs used all in association, and you can see that ACE inhibitors are present in this association of treatment, which many lines of drugs add, and with also what I omit to mention before, it is a titration of the dose. When you introduce ACE inhibitor, you introduce it very progressively, and also you have to have a blood pressure more than 9.5 for the systolic to consider that it is well tolerated, but in general is very well tolerated if you introduce it very progressively. Next slide. Now, what happened in real life? Is it done? This is a paper of two guys of Minnesota. Finally, despite these results, it is MDR data compilation. Only 60% of the patients suffering from Duchenne muscular were undertreated for the heart. Next slide. Another group in North America, it is an action group which was coordinated by Linda Kripes, which published and eplerenone in Duchenne, and with many centers, but all centers were have a cardiopediatric reference center. So they're not afraid to use these drugs, and they're not afraid to treat patients suffering from severe heart failure or with many disabilities. So in this survey, the results were different. Next slide, and were much more optimistic for us. Next slide. This is the groups, and you can see that at the age of 10, or the reason for indicating ACE inhibitor, it was age of 10 and mild systolic dysfunction, so a very minor level, or and in 68% of the patients, and in 23, it was mild systolic dysfunction or late enhancement of gadolinium on MRI, which traduce the presence of fibrosis, beginning fibrosis in the myocardium. So in general, when you are with a cardiopediatrician, you will have a good observance of the treatment and a good treatment of this patient. Next slide. For the beta blockers, in general, it requires to have a mild systolic dysfunction before the introduction. Next, and so it's well preventive. Next slide. And now, coming on the market, it is the SGLT2
Apologies, Professor Duboc. It seems like there is an issue with your audio.
When you have pardon? It's finished?
I think there is some
Hello?
issue with your audio. Yes,
Hello?
we can hear you better now.
You can hear me?
Yes, please continue.
Okay. So the glyphosine, I said the SGLT2 inhibitors are actually used in the patients suffering from Duchenne when they present heart failure or severe left ventricular ejection dysfunction. But the question is, will they be used as preventive treatment? Because also they have the capability of anti-fibrosis. So this is not clear for the moment, but I think, my feeling, they will join the preventive line of ACE, eplerenone, and beta blockers in a few years. But now they are already used in curative. And the other and last curative problem, it is the use of devices. What kind of devices for which patient, and in what perspective? So for the stimulation, it is clear we can do it when you have a large, wide cuirass. It will improve the performance of the B ventricle to synchronize the contractility of the left and the right ventricle when there are a conduction defect. No problem. CRT with pacemaker can be used clearly. The problem is the defibrillator and the left ventricular assistance device, or the artificial heart, I would say. Next slide. In fact, in the Linda-Gripes survey, the action survey, it can be used in 10%, the left ventricular assistance device, as a bridge to transplant. To transplant the heart. I think this is very exceptional, very rare. But when you see 74% of the indication is destination therapy, it means when you have no more heart, no more contractility, that you will die from heart failure. Some patient can have this device with destination therapy. It means in their wheelchair, they will have the machine, as they have the machines of ventilatory support, and to live with this new artificial heart. And it is actually the indication. In our group, we have some patients in destination therapy and except the problem of alarm of the machine, which is something to requiring a specific education. But this is, in my opinion, a good the own indication, I would say. And you can see that 16% do not use. Do not use 60% of the center do not use this therapy. And now for ICD, ICD, it is implantable cardiac defibrillator. It is only proposed in 60% of the centers. And as you can see, it's proposed essentially in patients which have left ventricular ejection fraction decrease less than 35%, many enhancements in the gadolinium and MRI, and also non-sustained VT. It means that they are very high risk of develop ventricular arrhythmias, which is, in my experience, quite rare, except at the very end stage of the disease. Next slide. So this is, I present you the classical therapy, but there is possibly great potential of other new therapy as gene therapy, but we have also many questions about the potential safety issue, and I think for gene therapy of the acute myocarditis. So it's probably still a little early to propose, except in terms of protocol of research, this kind of therapy. Well, thank you very much. I think you hear me.
Yes, thank you. I think, Carolina, are there still questions you would like to share?
Yes, thank you, Professor Duboc. There was a question about treating Becker patients and maybe at what age to start. So I would just give this one question. Thank you.
I think all the Becker 20 years old have to have a treatment in the absence of left ventricular dysfunction. And if at the MRI you observe a left ventricular enhancement, I will propose to them a preventive treatment based essentially on ACE inhibitors.
Thank you. And maybe one last one, just there was a question if you have ever seen abdominal pain after ACE inhibitors in patients?
Abdominal pain, no. In our controlled trial, we have just one adverse event. It was a bleeding, but the patient was on placebo. So the abdominal pain in this patient frequently, I don't know if it is the case for your patient, are essentially due to low cardiac output and liver hyperpression due to the increase in the pressure of the right ventricle. So it's finally frequently the abdominal pain frequently due to heart dysfunction, more than the treatment.
Thank you so much. There are other questions in the Q&A session. If you would like to answer them, we would love that. Thank you for your time, for your presentation, Professor.
And then it's up to me to give you another big thank you for this wonderful presentation. And I think it was very insightful for everybody. There were people who understand a lot about cardiology, but also the people who are just a little bit more, let's say, in the middle of the field. So thank you so much again. And then we now go to the next speaker who doesn't need a lot of introduction. That's Professor Eugenio Mercuri from the Gemelli Hospital in Rome. And he will speak about early interventions.
Good morning. I'm very happy today to share some thoughts about Duchenne muscular dystrophy. I will share my screen now. I will focus today on how an early intervention in Duchenne muscular dystrophy can produce a better outcome. These are my disclosures. And this is the outline. I will start with how we can identify early signs. I will then briefly touch on the diagnostic process. And the last part will be focusing on why it is important to recognize early signs, how it is important to have early recognition in order to have early intervention. We do know that achieving a timely and an accurate diagnosis of Duchenne is the crucial aspect of care. If we don't have a proper diagnosis, we cannot plan any activity. So it's very, very important that we identify early signs. And we know that Duchenne is a genetic disease, so it's present since birth. But when the children are born, there are no obvious signs of the disease, and even muscle biopsy is not very much affected. However, if we were performing CK in the newborn, we would find extremely elevated CK, not the mild decrease in CK that we can find in newborns after delivery, but very elevated CK in the terms of thousands. The first signs are generally between 3 and 7 years, and we will spend some time talking about these presenting signs. And we know that after the age of 7, there is more progression. Once you find clinical signs, and these are confirmed by increased CK, because you have to remember, always do a CK when you see some signs which make you suspect a muscular dystrophy, is start the diagnostic process. And this is very important, and it can be found very well structured in the care recommendations which were published in 2018. And very often, if there is a family history of Duchenne, if there are clinical signs, or if there is an increase in transaminase, we do serum kinase. And if the serum kinase, creatine kinase are elevated, we will go for testing of the gene. In the past, we used to do a lot of electromyography, we used to do a lot of muscle biopsy, but now we go straight for genetic analysis. And the genetic analysis very often will provide us some results in the majority of cases. And there are different ways of doing genetic diagnosis. In many countries, MLPA is still the most used method. And MLPA will provide to find deletions and duplications, but not the small mutations. If in your country you start with MLPA and not with CGA array, CGH array, or more modern and expensive technique, if the LPA does not detect deletions and duplications, then we go to the second step, which is sequencing. The sequencing will allow to identify small mutation that can be of different types. These are the deletion of the duplications, and the sequences the sequencing will allow to find very small mutations that cannot be detected by MLPA, like nonsense mutation, small mutation within the exon, like insertion of deletions, splice site mutations, and so on. And we know that this is extremely important, the genetic confirmation, because there are some treatments which are available that are specific for some deletions, like the exon skipping, or like for Translarna for nonsense mutations. If genetic testing does not confirm neither the MLPA or the sequencing confirm there is a mutation, then we go to muscle biopsy only in these cases, because we want to make sure that the weakness we see of the increased CKs are related to a specific protein, because this should also be another muscular dystrophy, and the muscle biopsy would provide us information whether it's sarcoglycan or a congenital muscular dystrophy or so on. Muscle biopsy is now performed only in these cases. There are different ways of looking at the muscle biopsy, but what we normally do, we want to look at dystrophin expression. Well, first if there is a dystrophic process, and then the dystrophin expression with different methods. We also use muscle imaging. At the time when we are waiting for muscle biopsy and we have increased CK, we don't do electromyography anymore, but we do muscle imaging. This is very quick. Children are not bothered. It's not painful like electromyography. You can see sometimes we even teach children how to do it themselves. And the the muscle imaging, the ultrasound can give you information. This is a normal ultrasound. You can see this is the subcutaneous fat, and these are the individual muscles separated by the fascia in between muscle. And you see that this is the normal echo of the muscle. And this is the bone over here that you in transversal you see like this, and you see rounded like this if you do a coronal. If there is muscle abnormalities like in muscular dystrophy, instead of seeing this dark signal with this echo, you see increased echogenicity like a snowstorm, and this indicates that the muscle is involved. The timelines for diagnosis is still around above 4 years in several countries. And so it's very, very important that there is a lot of teaching to pediatricians, orthopedics, to send the pediatric neurologists for diagnosis. I will now go to the third point, which is why it is important to recognize early signs. The first thing is that if we have an early diagnosis, we can provide more appropriate genetic counseling. First of all, we will do a carrier status in the mother. We have many families in whom there was a second boy that was born before the first boy with Duchenne had the diagnosis. So we have to know what is the risk of recurrency in that family, knowing the carrier status of the mother. What is the risk in young siblings or cousins who may be already born and not know that they have Duchenne muscular dystrophy? And this will help a lot also to plan further pregnancy, to know exactly what is the risk, antenatal diagnosis, and so on. So early diagnosis is important for genetic counseling. It's important for aspects of care like rehabilitation. So we will see in a moment that many of the children will have developmental delay, and very often some milestones are not related to weakness, but to a delay. And if we start early intervention, we can help the child in improving these aspects a bit faster, and we can prevent contraction. So it's important for counseling, it's important for rehabilitation, and this is important because we know that if we assess children in the early stages before they go to school using developmental scales like the Griffiths that we use in the first study, or the Bailey scales that we use in the study by Anne Connelly and others, we will find that these children already have a quotient of development which is on average one standard deviation below that of their age-related peers, as we see with cognitive function later in life. And there are different aspects. These scales calculate a lot of aspects which go from locomotor to more cognitive aspects like personal, social, hand-eye coordination, hearing and speech performance, and so on. And what we find is that the locomotor scales is often involved in all the children. 78 is a low score, and is involved irrespective of whether the children have mutations in one side or another. While this is not related to the type of mutations. All the mutations have locomotor points. However, if we want to look at other aspects like hearing and speech and performance, these aspects are more related to where the mutation is, because we know that the site of mutation can be associated with the involvement of brain dystrophin isoform. So if a mutation is after exon 45 or even more 51, there is a higher risk for having cognitive impairment and the delay. And this is even more true if the mutation is after exon 63, because this affects another brain dystrophin isoform. So if we look at the results of our scales, the children with mutations between 45 and after 62 have lower results also in the more cognitive tests. So another important point is that we have to recognize that there are some aspects that early in life are already affected by weakness. So children are not able to run fast or to jump or to get up from the floor very quickly without hands. And this is due to the weakness and does not improve with time. While there are other aspects like standing on one leg balance, jumping from a set, going up and down stairs, that children at the age of 3 and 4 may have some difficulties in performing these items, while their age-related peers, they will already be able to do it, and they will need some time. But this is just a delay, because eventually, if you test them after a year or so, they will be able to do it. So we have to identify some aspects which improve with time, and some aspects which are due to a delay. And these are personal, social, hearing and speech, hand and eye coordination, and performance. And I will go briefly on this, just to remember that we have to keep in mind that there are some signs which are related to weakness and don't improve with age, and others which are related to the brain dystrophy, isoform involvement, that are just a delay, and they are not related to weakness, and they will improve with time. Now, why is important to recognize intervention and that can be provided? Because we know that there are a number of drugs which are already available, like steroids, and now vamorolone it has already been approved in some countries, and hopefully will be approved in other countries, that can help the children very, very early in life. We have a lot of experience with steroids given when the children are at the age of 4. And but there are also other drugs that are available now, and others that may become available in the near future. So if we know that there is a problem, there is a diagnosis, we can start treatment very soon. And these are some of the options which are available, like exon skipping or the premature stop codons of the nonsense mutation, as we have already anticipated. And why is it important early treatment? If you look at how muscle biopsy changes in Duchenne, you can see that from the time when the children are born to the age of 3, there is already a change. You can see there is a loss of the normal architecture of the muscle. And if we wait until the age of 7, at the age of 7, the muscle is much more evolved, is much more impaired than at the age of 3. And if we look at the early dates, we can see that we hardly recognize muscle tissues. There is a lot of fat replacement, which is the white part that you can see. So we know that there is progressive muscle damage. So the earlier we intervene, if we can intervene very early, we can save more muscle from the progression of the involvement. And this can also be shown on MRI. If you look at an MRI at the age of 5, you can see that the muscle is much more preserved. This is how a normal muscle looks like. And if you go to 8 and 9, you can see a lot of this white signal, which is fibrosis and fat replacement, which becomes more obvious with increasing age. So if we intervene here when there is more muscle left, this is in the thigh, which is important for ambulation and so on, we have more chances of reducing the progression of the disease. So it's very important early diagnosis, because if we have drugs available, we can have a better chance of preserving the muscle. And this is what happens in the Duchenne, as you all know very well. We have the diagnosis, then we have loss of standing, then we have loss of ambulation, and then a number of other important steps which will bring to loss of upper limbs, respiratory and cardiac problem, and eventually at death. And we always start and focus on the first part of this, when the muscle is more spare, which is the time because before the children are losing ambulation. And one of the aims of the treatments is really to prolong the time when the children lose ambulation. And we always focus on loss of ambulation, but if you talk to families, they will tell you that after loss of ambulation, there are other important milestones that are important also for respiratory function, or for other important motor function like hand to mouth and so on. And there is this very nice study performed by the Synergy group by Professor McDonald and his group, who showed that if you look at children who have lost ambulation at different ages, and you look when other factors like loss of a hand to mouth or FVC occur, you can see that the children who have lost ambulation before the age of 10 years also require FVC, have a lower FVC, requiring non-invasive ventilation earlier in life, and the children who lose the ambulation much later, after the age of 13 years, will require non-invasive ventilation later in life. So it's important to remember that there is a chain of events that if we delay loss of ambulation, we also delay loss of upper limb function, loss of respiratory function, and other milestones, including cardiac. And this paper shows very nice the effects on all these aspects. So what are the conclusions? Is that the conclusions are that it's very, very important we as clinicians can recognize Duchenne as early as possible. I'm pretty sure that you as a pediatric neurologist or people who know about neuromuscular disease recognize Duchenne immediately if they see a child. But this is not always the case with pediatricians or for neurologists who don't have experience with neuromuscular disorders, because don't forget, this is a rare disease, not everyone has your experience. So it's very important to do some teaching to the pediatrician, to make pediatrician orthopedics aware of the importance of recognizing early signs. It's important pediatricians to make aware that an increase in transaminases is not necessarily a liver problem. There are still children who have liver biopsy because they think of Duchenne muscular dystrophy. So making your colleagues aware is an extremely important point. It's very important that once we identify the children, we provide early standards of care, rehabilitation, steroids, or vamorolone if this will become available, and any possible intervention we can provide as early as possible, night splints, and so on. And if there is a therapeutic intervention available, to start providing this, because we know that these drugs that are available can provide a delay, not only loss of ambulation, but also in the subsequent milestones. So early identification is extremely important, and this has been causing a delay in the shift in what we know in the natural history of the Duchenne. When I started in this field, the children were still losing ambulation at the age of 8.5, and they were losing by the age of 18. It has been the early identification and the possibility to access standards of care, which have already improved quality of life, survival, and time to loss of ambulation in these children, but we want much more. So it's very important that we work all together on these aspects. Thank you. And I'm very happy now to take any question. Thank you.
So the questions he can't take as he is online at this in this meeting. But a big thank you to Professor Mercuri for always being willing to present. And if you have questions, we will forward them to him and hope he will answer them as soon as he has time. And we thank him also for recording as he was not available in person today. So now we want to go to Professor Imelda de Groot. She was already there yesterday, so we had a brief introduction already, but this presentation is about the Accredited Duchenne Center, a program of the World Duchenne Organization, where Professor Imelda de Groot is the leader and has done a lot of work to make this program a success. So the floor is yours. Thank you.
Thank you, Elizabeth. I will try to share my screen now. And hopefully it works.
Yes, this is perfect.
Okay, thank you very much. Well, I'll try to keep it short as we are running out of time. So I'm the leader of this program, but the initiative of this program was the World Duchenne Organization, and they had one big aim, that to get uniform and optimal care all around the world. And although I was asked to be the leader of the program, I couldn't do it my own, so I've got an excellent team surrounding me, and you all know Elizabeth, and you all know nowadays also Karolina Podolska, who is the program manager, and we have a second program manager, Merel Jansen, and we also happy to have Noël Laloute, who is the responsible for the data management, and of course Susie Bakker, you all know her, and she is our communication manager. what team could be better. But we're not doing it alone. We are also having an advisory board. And if you look at all the pictures and the names underneath it, you can see that they're widely experienced in the field of Duchenne muscular dystrophy. And there's also a patient representative, a Dr. Agi Golan, but she is a patient representative in this advisory board. The advisory boards have helped us immensely when we were starting up the program, setting the definition of an accredited center, setting of the criteria for accreditation, and also in all kinds of procedures we developed within the program to eventually get to an accreditation of a center. This is the definition of the accreditation. Well, it should be a center that works according to the latest standards of care, the guidelines, the consensus guidelines, or the expert opinions. So this means that in future, the criteria can change because there can be new insight or new evidence. Additional criteria can be added or other criteria can be changed. Essential is also that the care is provided multidisciplinary, and this can be delivered in one center, but it is also possible to share it with other locations. However, the applying center is always responsible for the care plan, coordination, communication, documentation, and collaboration. So this is the process we designed. It starts with registration. You can get to our site or send an email. The addresses are at the end of the presentation, that you are interested in the program. And if you're interested and want to apply, we send you a pre-visitation questionnaire, which is the screening session, screening phase. And in these pre-visitation questionnaires, already the criteria are mentioned, most of them. And if you fulfill those, then we plan a visitation. The visitation is done always by a committee of 3 persons, 2 doctors and 1 patient representative, because in the visitation you will also going to talk to patients and their experience next to the professionals of the applying center or the shared centers, shared care centers. And the committee will discuss this with the program team, and if we agree on all criteria are met, then a center gets his accreditation. But it's also important to maintain accreditation. This means that your knowledge should be up to date. So you have to follow education. And after 5 years, we are going to reevaluate a center to see whether it's still up to the criteria. Up to now, for accreditation, the care considerations of burn control are used for the pediatric and adults, but also the consensus guidelines of Professor Quinlivan and Narayan for the adults. So we're looking at centers that treat only pediatrics or pediatrics and adult patients, but and also adult centers only. Where are we now at this right moment? We have done the startup phase, so we have defined the accreditation, we have defined the criteria together with the advisory board, and we have developed the questionnaires that are sent to the centers and also the interviews. And we are starting to build up a database. And we have finished now the pilot recently. We have visited 3 centers, and we are now planning the next visitations to the centers that are still waiting to be visited. We are also have the intention to get more education on certain topics. As we visit more centers, we will notice which criteria are hard to meet. And we are taking, for example, one of the criteria is the use of ACE inhibitors, and you just heard a nice talk about it. But we are also thinking of developing webinars on specific topics. And after that, we are planning, well, we hope that we can create a network of accredited centers that are collaborating, and we are also thinking of the next 5 years when we have to reevaluate the accredited Duchenne centers. Well, we have developed a website. You can see the address at below of the slide, and there you can read about our program. We are building a database now, a FAIR database, together with Mark Wilkinson, which is an expert in this field, and we really need him to do this. And we want to do some analysis, for example, on the data, which is a hard criteria to fulfill. Should we develop topics on that or not? It educates the guideline. And next to the FAIR database, we will have a raw database where all the materials of the process will be stored. So if there is a discussion about a decision, we can still look back at everything. At what moment are we standing right now? The 35 centers have expressed their interest, and 27 have really applied. These centers are from 16 countries, all of the continents except Africa. So people from Africa, just think about it. We have finished 3 visitations, and we have now finished the pilot phase, and we could have done 6, but unfortunately, 3 completely prepared visitations were cancelled because of the reasons beyond our control. We have planned now 2 visitations in June, and 5 centers are ready for visitation now, and we are planning those for after the summer and next year. So all the remainder centers are still in an active process to reach the visitation criteria. There are several benefits if you are an accredited center. Well, of course, it improves and uniforms the patient care, but it also guarantees a little bit to the patient and the family some confidence, because this is a center working according to the guidelines. We hope it can give collaboration and networking between the centers, and one can learn from each other, but it also gives some funding opportunities and reputation. And if you're one of the accredited center, you will always be reached out if there are new education programs within the Duchenne care. So all your team are allowed to follow these educational activities. These are some quotes of the centers that were already visited or are going to be visited, and I'm not going to read them out loud to you, but the main thing is that they enjoyed the visitation much, because we are not taking an exam, but we are in discussion and making suggestions to a team to improve the care. So it's an interaction between the team and our committee, and we all like to improve the care and give the best care to the persons with Duchenne. So as a team ourselves, what have we learned? Well, we have learned that centers work within the possibilities of their country. We have visited 3 very different countries, and the nice thing is that they all reach the same goal, but with different approaches. And we also noticed that telemedicine is frequently used. But there are also many leaflets and brochures or all kind of interesting materials available in centers. However, nobody knows about it. So hopefully in future, we can exchange those leaflets, and you can adapt that then to your own center. But to end this talk, I also think that patients are very inventive. You see on the right side a picture of a young man in Mexico. And in Mexico, wheelchairs are only either bought themselves or given by a patient organization. There's no insurance for it, and you only get a manual wheelchair. And this family managed to make a hoverboard attached to the wheelchair, and the guy could ride with his wheelchair, semi-electrical, through the hospital and through his house, which is very inventive, I think. We can learn about that. So I would like to thank you for your attention, interest, and at the bottom you can see our addresses where you can find more information about our program, and hopefully you apply. Thank you very much.
Thank you, Professor De Groot. And again, from me, as I'm part of the ADC program, I also really want you to look at our website, and please contact us if you have any questions. And now the floor back to Elizabeth and to the next speaker. Thank you.
Thank you. Were there any questions for the accredited program in the chat or not? Okay, so that's good. So I don't have to promise like they will get an answer by email. So thank you. And then our next speaker is about a very interesting subject. And this is Dr. Mahalekshmi Desikan from the UCL. She works with Professor Ross Quinlivan and looks after and studies Duchenne muscular dystrophy in the adult population. And many clinicians don't have kidney problems on their radar for DMD. I think what we see is if you're lucky, you have a cardiologist who's checking some blood work, but other than that, we don't see it a lot. So we are very grateful that you will present about chronic kidney disease in adult DMD, and the floor is yours.
Thank you very much. Can you all hear me?
Yes.
Thank you. Good afternoon, everyone. So I'm Lakshmi. I'm a neuromuscular specialty doctor from the National Hospital for Neurology and Neurosurgery in London. And as was alluded to, I work with Professor Quinlivan. Today, I'm going to talk about renal management in adults with Duchenne muscular dystrophy because I work in an adult center. I'm going to focus mainly on the diagnostic aspects of this prior to referring for further management to a kidney specialist. Next slide, please. So before I go on, I have to say that my disclosures are I'm involved in clinical trials for Edgewise, Santhera, and PepGen Pharmaceuticals. I'm a sub-investigator for these studies, but there is no relevant disclosure for this particular topic I'm going to talk on today. So we have heard that Duchenne muscular dystrophy patients are now living much longer, into their fourth and even fifth decades, with excellent multidisciplinary care as well as corticosteroid therapy. Therefore, DMD is now a chronic condition in the adult population, and renal failure is increasingly recognized as a cause of morbidity and mortality in our patients, especially the non-ambulatory adult population. Yet there is very little literature on this compared to cardiac, respiratory, or orthopedic, or any other domain of DMD management. Next slide, please. The first reference to renal disease in DMD came in around 2011. Matsumura et al., they performed a longitudinal cause of death analysis of patients with Duchenne muscular dystrophy. So there were about 286 adults. Dating from 2004 to 2010. And they found that renal failure was a cause of mortality in 14% of this particular cohort. So there were 42 deaths, of which 6 were related to renal failure. All these patients were on ACE inhibitors and beta blockers, and they first raised awareness of the possibility of a cardiorenal syndrome in Duchenne muscular dystrophy. So by this syndrome, what is meant is that whenever there is an acute or chronic dysfunction in the heart, that can cause an acute or chronic dysfunction in the kidney and vice versa. And the same group published a year later a report of 6 patients who died of acute kidney injury despite good cardiac function. And they looked at what the contributing factors could be, and that included chronic hypovolemia from low fluid intake, diuretic therapy, as well as diarrhea, so intercurrent illness, mainly fluid losing conditions like diarrhea. They used cystatin C as a measure of renal function, and they also looked at a population of 103 Duchenne muscular dystrophy patients ranging from 7.5 to almost 50 years of age, and they looked at their cystatin C levels at one-off data. And they found that over 30% of their population over 30 years of age had higher cystatin C levels. So what exactly is a cystatin C? It's a cysteine protease inhibitor. It's also a lysosomal proteinase inhibitor within the cell. It is produced by all nucleated cells in the body. It's filtered by the renal glomerulus. It's partly reabsorbed by the proximal tubule and it is metabolized, but it's not reabsorbed back into the bloodstream. And it is a good indicator of kidney function. Next slide, please. Subsequently, a group from Belgium looked at renal function in children and adolescents with Duchenne muscular dystrophy. And they had around 20 patients in their cohort, aged 5 to 22 years, of which most of them were on steroids, according to standards of care. Almost half of them had high blood pressure, possibly steroid-induced. And about 2/3 of this group had a non-dipping blood pressure profile, by which there is no the nocturnal drop is less than 10% of daytime blood pressure, as would be expected in a physiological state. And they also observed that the median glomerular filtration rate in this group was inversely related to age. Interestingly, they noticed that serum creatinine-based equations overestimated glomerular filtration rate by up to 300%, and cystatin C-based equations were much more representative of true GFR in the Duchenne patients. Next slide, please. Another Japanese group in the same year looked at treatable renal failure in their cohort of non-ambulatory Duchenne muscular dystrophy patients. They had 4 cases, aged 18 to 36 years. And the main predisposing factors for hypoperfusion were chronic decrease in oral fluid intake in 2 of those 4 patients. All of them had cardiac dysfunction, and all of them were on a diuretic. And renal failure improved by increasing fluid intake in these patients and discontinuing or optimizing the dose of diuretics. 3 of their patients were also noticed to have anemia, and this could have also contributed to an increased cardiac workload, potential cardiac decompensation, and renal perfusion. So they looked at cardio-renal anemia correlation in these patients. They also commented that cystatin C clearance is a much more reliable marker of kidney disease in DMD patients. Next slide, please. Then came the study of Villa et al. From the US. They looked at how they could identify cardiorenal syndrome in patients with DMD using cystatin C as a sole marker. So 12% of their patients had evidence of renal dysfunction measured by cystatin C eGFR. They also found that there was a significant correlation between left ventricular ejection fraction and cystatin C eGFR in those patients with chronic left ventricular dysfunction. So the moment the heart starts failing, the cystatin C eGFR starts dropping. They did not particularly find any relation between creatinine-based measurements and left ventricular dysfunction. So they concluded that cystatin eGFR correlates with cardiac dysfunction in DMD patients. And the cystatin eGFR did not vary with age in their cohort or steroid doses. Next slide, please. So from all these studies, what really is striking is that most of these patients seem to have low oral fluid intake. All of them have cardiomyopathy, especially when they come to adult, they transition to adult services. And all of them nowadays are on ACE inhibitors and a mineralocorticoid antagonist like eplerenone or spironolactone. And the combination of the above 2 makes them have a low baseline blood pressure. And any intercurrent illness like a diarrheal disease can cause drop in blood pressures and further impair kidney blood flow, perfusion, and result in acute kidney injury. One has to remember that our patients have reduced skeletal muscle mass. So serum creatinine is very low, and creatinine-based eGFR is not representative of their kidney function. And anemia, in particular, can worsen their cardiac as well as renal outcomes. So this is the gist of, the summary of all these reports that were published until 2016, 2017. Next slide, please. So the standards of care document in 2018 did not particularly address renal issues in Duchenne muscular dystrophy. Next slide, please. The consensus statement in 2021 September from the Adult North Star Network group in the UK did include some guidelines for renal monitoring in Duchenne muscular dystrophy. Next slide, please. So the recommendations given by this consensus group are that urea, electrolytes, and cystatin C must be measured annually in all patients with Duchenne muscular dystrophy, especially in the non-ambulatory group. More frequent measurements may be needed if there is a change in the dose of cardiac medications, especially the diuretics and ACE inhibitors, and if there is an intercurrent illness that, again, necessitates change of cardiac medication doses. And if abnormal cystatin C is documented after lab testing, One can calculate cystatin C-based EGFR. There's a calculator which is free and is available on the National Kidney Foundation website. If the EGFR is measured to be low, a nuclear medicine GFR scan can be organized, if available, to assess true glomerular filtration rate. And if the patient has kidney disease, they can be referred to a nephrology team for further management. It is very important to correct anemia, either via oral iron, infusion of iron, or erythropoietin injections. And fluid intake should be encouraged in all patients. And oral fluid intake is sufficient in patients who are not acutely unwell. However, in the acute setting, one may need intravenous fluid replacement. Next slide, please. So dehydration is the single most important reversible factor contributing to acute worsening in kidney function in our patients. And it also puts the patient at a higher risk of developing kidney stones, which can be observed in about 1/10 adult population with Duchenne muscular dystrophy. So this is a leaflet that we use in our DMD population, which was developed by my colleague a couple of years ago. Next slide, please. So where I work in the National Hospital for Neurology and Neurosurgery in London, I did a cystatin C audit from 2018 to 2023 in 116 patients. Why I chose 2018 is that that's the first patient, so that's the first time when we did have a documented patient with chronic kidney disease. And from then on, I looked at 5-year data. So our center, the Neuromuscular Complex Care Center, is a 6-bedded purpose-built unit for multidisciplinary assessment. So we have cardiac, respiratory, gastro, psychology, psychiatry, neuroanesthetists, all these consultants, they come and review patients under one roof. We also have a very dedicated therapy team. Next slide, please. So this slide is probably not very clear. So this is the data I presented in the World Muscle Society meeting in 2019. And this included about 4 patients who had chronic kidney disease. From 2019 to 2023, I've identified 4 more patients in our cohort. So I will move on to the next slide, please, which is much more clear. So this is the first 4 of our 8 patients. You can see they were Caucasian, Asian, Afro-Caribbean, so ethnicity did not matter. All of them, the underlying feature was moderate to severe cardiomyopathy. They were all on ACE inhibitors and diuretics. All patients had anemia diagnosis. In fact, patient number 2 came into light mainly because of anemia. That was picked up by a respiratory team in a different hospital, and he was asked, to have further investigation. That's how we picked up his chronic kidney disease. Not everybody had increase in urea from their baseline. Again, same goes with creatinine as well. Even in those patients who had an increase in creatinine from their baseline, the absolute level of creatinine was very much within normal limits. So if we went by one single value of creatinine, we could have easily missed this. All of them had raised cystatin C levels. We tend to do a kidney, ureter, bladder ultrasound in all these patients just to exclude any obstructive uropathy as a reversible cause of kidney impairment. And having excluded that, we organized EGFR nuclear medicine scans, and that was diagnostic of chronic kidney disease. Next slide, please. So the next 4 patients are here. So again, 21 to 31 years old, Asian, Caucasian population with moderate to severe cardiomyopathy. Again, on cardiac medications, all of them were anemic. Variable increase in urea or creatinine from their baseline, but all of them again consistently had raised cystatin C levels. And nuclear medicine EGFR scan was diagnostic in 3 of them. In one patient, unfortunately, the scan failed because venous access was very difficult, so we couldn't scan him. But the cystatin C levels were well over the 4.5 mark. So the cystatin C based EGFR was less than 60, which was diagnostic of chronic kidney disease. Next slide, please. So as I said, anemia was the first sign of renal failure in one of our patients, and it could have been missed if the other team, the respiratory team, hadn't picked it up and referred him back to us in time. 2 of our patients could not have ACE inhibitors anymore because every time we try to reintroduce ACE inhibitor, even a very low dose, the kidney function worsened drastically. One of our patients had severe cardiomyopathy, developed acute gout, unfortunately. So he wasn't furosemide because of as a diuretic for cardiomyopathy treatment, and we had to reduce the dose of furosemide as it has a side effect of hyperuricemia. And one has to remember, in patients who do not have neuromuscular disease, urine albumin creatinine ratio is quite useful as a marker of renal impairment. But in our patients who have very low creatinine values, this is not a useful ratio at all. Next slide, please. So I just want to summarize. These are the points that I want to actually tell everybody. Consider chronic kidney disease in Duchenne muscular dystrophy patients who have rising urea and creatinine, anemia, as well as raised cystatin C levels. To emphasize again, creatinine level can rise from baseline, but it can remain well within normal limits. So please do serial values of urea and cystatin C level to establish a diagnosis. Rising urea could be a marker, but urea is also high when somebody is dehydrated and has upper GI bleed, upper or lower GI bleed, actually. Cystatin C levels are quite useful in these patients, and they must be done, if possible, if available, as standards of care for these patients. Level can also be affected by systemic inflammation, adiposity, thyroid disease, and by steroid use. The main problem with cystatin C estimation is that the cost of doing cystatin C is almost 10 times more than that of doing creatinine, and it is not widely available in many centers. One has to remember that anemia could be the first sign of renal impairment, and correction of anemia is essential for management of both cardiac and renal issues. And one must not forget hydration. So in patients with poor oral intake due to dysphagia, consider enteral feeding options for long-term management of fluid balance. Next slide, please. And I want to thank you all for being patient and listening to me. This is a very few slides because there is not much literature on this topic. I'm happy to take any questions or any comments. Thank you.
Thank you so much, Dr. Desikan. We know that renal complications and renal disease has not been a big topic in Duchenne, and we are so glad we had your presentation here today, you with us today. I do have a question. What is about the percentage of patients that have Duchenne and renal disease that you follow, or percentage of patients that you follow overall in your center?
So we have, in the last 10 years, we have had around 190 adults with Duchenne muscular dystrophy that were looked after by us. But as I said, my, my audit only included about 120 patients who were seen in the last 5 years, of which 8 had, chronic kidney disease. I have to look at the percentage. I'm not very good at doing mathematics very quickly, but it's not a huge number. I would say less than 10% in our cohort.
Yes, we're trying to raise awareness about renal complications in Duchenne. So this is what I was going for, the percentage, because, for example, in our adult care, it is hard to make the clinicians really test the cystatin C that you mentioned, because as you mentioned, creatinine does not help you at all. So you need to go for further testing. Okay, thank you. And if any further questions are for Dr. Desikan, she is here with us, so she can answer in writing. Thank you so much for your presentation.
Thank you.
Now we give the floor to Elizabeth Vroom, but not today as the moderator, but she will now have the floor as a presenter on the white paper on newborn screening in Duchenne. She's not only the president of World Duchenne Organization and former president of Duchenne Parent Project Netherlands, but she's also author of numerous papers on Duchenne, on standards of care, drug development, development of outcome measures, role of biomarkers, and trial design, and better use of data. So Elizabeth, the floor is yours, and thank you so much.
Thank you. This is for this super kind introduction. Yes, well, as we have all seen over the last years, we have been talking about newborn screening, and even since for Duchenne, since 1997, when we had the famous meeting in Rotterdam, the first European meeting. And there have been like 40 pilots on newborn screening for Duchenne, but still there are very, very few programs included, let's say. So at this moment, as you maybe remember, last year we had 3 speakers on newborn screening, and one of them was Professor Martina Cornell from Amsterdam, and she also explained that newborn screening is not something we can do internationally. It's something we can speak about international, where we can encourage. But at the end, it's you, the people in the countries, and even in sometimes in regions, that have to fight for newborn screening. So the best we could do as World Duchenne Organization is to create a new a white paper on newborn screening. So you have kind of material, arguments, literature, scientific literature, experiences in one paper, which you can use to go to your national or local authorities to discuss newborn screening. And this white paper will be available online from tomorrow onwards. There will tomorrow be a press release. A lot of people have been working on this. There was a working group where some of you who are now online were part of. There have been reviewers, there were the writers, including Kimi, and also the families for the pictures and the quotes. So this is the look of the paper. And as I said, from tomorrow on, it will be available. It is like 40 pages. So it's really not just a pamphlet. It's a very thorough work. And again, thank you so much for everybody who has helped us to do so. And then I think at this moment, it's the time to say farewell. Thank you so much. With this, I end the last day of the World Duchenne Care Conference 2024, but not without already showing you the save the date for 2025. Please put in your agenda and spread it amongst your colleagues and members. Only together we can improve care. Again, a big thank you to everyone who made this conference possible, and to the people online for watching. And don't forget to fill out the evaluation form so the conference can even get better next year. And Suzanne is already sharing the save the date for next year. If you promise to put that in your agenda, I say farewell to you. I hope you have a good afternoon, evening, whatever it is in your place, and see you soon. Bye-bye.